I'm going to tell you something in the next 15, 17 minutes about no, that's not a good presentation, so we're going to change it. Okay, they're very good. They're very fast. Optimizing no, that's not good. Okay, this is my presentation. Optimizing neural function in return to play, use it or lose it. So I will really focus on the neural function. I will have such an approach that you will understand a little bit more here. So I do not pretend, so I am a scientist, I'm not a physio, I'm not a doctor, I'm a sports scientist with a fascination for neuromuscular system and in particular for the neural part. I appreciated very much this slide, and I think we have to step back maybe and say, okay, RTP is multifactorial. We saw several times physical factors affecting RTP. We spoke a lot about psychological factor. The aim of my talk is a little bit to bring you into a dimension that I will call neural, if you want to call it neural training or neurally oriented training, that will help you probably to bridge the gap between those two main factors. You already saw this kind of animation yesterday, so the goal is really to focus on the main impairment. And if you agree with me, and I think there are many therapists who agree, for example, that for the knee, arthrogenic muscle inhibition, which is a neural impairment, is one of the main problems, both for you as a therapist and for the athlete. Then you will agree, probably, I mean, this is just a proposal, that treating neural impairments will probably help you optimize the RTP process. So let's define the neural limitations very quickly. So we don't have to go into neurophysiology, but we're going to simply see what happens when there is an injury or when there is surgery. Even worse, when there are both of them. So this is simply how I see the neuromuscular system. I only refer to in vivo studies with humans. I will never refer to animals or to basic science studies. What you see in red here is what we call sensory feedback, what comes from the periphery, from the receptors. And we know well, since a long time, that as soon as there is injury, as soon as there is joint surgery, there is a cascade of impairments, in particular at the sensory level, which will result in an increased discharge rate of the different receptors due to a bunch of problems induced by injury and or surgery. And in turn, this will result in a confusion at this level here, because this information goes up to the spinal cord and then up again to the cortical centers, where we have an increased activities of those receptors. We call it sensitization, peripheral sensitization, going up here and creating a lot of confusion, so that your brain is a little bit disoriented when we receive all this bunch of information from the periphery, from the receptors. So with altered sensory feedback, we also have to consider, unfortunately, that as soon as there is an injury, as soon as there is surgery, there is a sort of disuse. Disuse is reduced activity or immobilization in the worst cases. And disuse, unfortunately, also induce tons of neural impairments that we know today very well. Just quickly to remind you, the two main impairments when we mobilize a person, and we know from these studies, so these studies are done on healthy people, so they don't have the sensory impairment. So this is a little bit underestimated, what I present you. But we know that after a few days, and this is one of the models, so we mobilize a finger for a few days, and that's what happens after 1, 2, 3, 4 days after immobilizing a finger in a healthy individual, so the joint is fine. You have a reduction in the corticospinal excitability. You don't have to go into difficult words, but basically into how well your brain helps the spinal cord to activate and to drive the muscles. And we also know, for example, that the cortical map, which is nothing but the quantity of neurons that are active during a given contraction, is dramatically reduced after short-term immobilization. So there are huge neural impairments, which, together with the altered sensory input, will result into what we know. We know since 50 years that as soon as there are these troubles induced by injury and or surgery, there is the so-called arthrogenic muscle inhibition or inability to fully activate the muscle, which is a problem for the muscle, which is a problem for the therapist, because he will never be able to train, to rehabilitate part of those muscles. So this is the seminal work of DeAndre on the definition of arthrogenic muscle inhibition. Today we have a bunch of techniques that can also be used to do that, and there is plenty of evidence to say that arthrogenic muscle inhibition is the cause and one of the main problems that should be treated in patients with injury and surgery. I will mainly refer to the knee and probably mainly to ACL and total knee arthroplasty, but I think the model I will present will apply to a bunch of applications. And that's the problem. So if we take our fibers, these are the motor units, but if we take the fibers, which is the same of your muscle, and then we organize the fibers as they are usually activated when you do a contraction. We know that from Henman size principle. The problem will be that those fibers here, the white fibers, the fast fibers, will be those very difficult to activate when there is arthrogenic muscle inhibition. So you as a therapist will be mainly working on these fibers. And these will be, and in particular those fibers, the fastest fibers and the strongest fibers, will be difficult to train. And with this arthrogenic muscle inhibition, we will have an impairment in motor function that will be very clear at the beginning, that will be confirmed even after several months, sometimes after several years. So I see the muscular changes that are usually observed even a long time after surgery and rehab as a consequence. I don't see the muscular changes as a cause. The atrophy you see in your patients is, according to how I see that, it's simply a consequence of reduced activation. If we do not activate these fibers, they will atrophy. They will get fat infiltration into those fibers. And that's simply a study with very strong evidence, few people, but 10 years after ACL reconstruction with hamstring autologous, recreational athletes, fully rehabilitated, fully returned to activity, and this is the atrophy in semitend and gracilis muscle. So 58 means this is 58% of the contralateral non-operated side. This is 54% in the 10 people of the contralateral side, which is huge, which is what you see probably when you look at the thighs of your patients and also look at the quad. So here we are not speaking about patellar tendon reconstruction, we are speaking about hamstring, but the quad is also atrophied by about 10-15%, 10 years after reconstruction. So for me, these are the consequences. And how to address then those neural impairments, which again, for me, they are the main impairments we should focus on. I think the only thing I can do is not to provide a strong model with strong evidence. What I can do is to provide some hints on how to try to optimize the different steps of the neural impairments. So this is my proposal with a 4-step approach. This is chronological, and I will show you how it can be integrated into a normal rehabilitation routine, for example, for ACL. Step number 1, normalizing the sensory feedback. So renormalizing how your receptors send information to the brain. Number 2, maintaining brain activation. So maintaining the activity here in this area. Number 3, improving muscle activation, improving how the descending drive will activate the muscle. And number 4, and more likely, and I will insist a lot on that, improving rapid activation. We don't need to contract, we need to contract as quickly as possible. My approach will be with 3 main keywords. Number 1, home-based, because we need a lot of engagement from the patients. We need to provide as much education as possible on what we're going to do in this direction. We need commitment. These are keywords I also recognize from previous speakers. We need variation, and that's probably the best thing you can do as a therapist. You will always need to surprise the nervous system. The nervous system is extremely intelligent. As soon as you do 2 times the same exercise with the same load, the same velocity, you will have no more adaptation. So you will have to consistently surprise the neural system to avoid stagnation. Number 3, progression. It seems very simple, but progression should be the core of this program with clear objectives. So clear objectives means, okay, today you can do a drop jump with 1 centimeter, today 2 centimeter, the day after tomorrow 3. These are objectives. We are speaking to people who are frustrated because of the injury. We need to provide clear objectives showing the progression with feedback and trying to maximize the plasticity. Okay, this is one of the classical models for rehab after ACL reconstruction. So that's by Wilk. It was published in 2012 with 6 classical stages. One pre-op phase, one immediate post-op phase. Here you have the injury, the surgery, and the return to play. And then the numbers refers to the weeks as compared to the surgery. Then you have an early rehab phase, controlled ambulation, advanced activity, return to activity. I just presented here the goals for the different phases according to neuromuscular function. I did not present those related to healing, for example. And how we could integrate this conceptual framework into that would be quite simple in theory, with a couple of approaches proposed for 2 phases. So if I would have to select and to decide when to do normalizing sensory feedback and maintaining brain activation, I will do that as quickly as possible, even 10 minutes after the injury. So we speak about pre-injury, post-injury, pre-surgery, and we speak about a week after surgery. Second phase for the conceptual framework will be continuing to maintain brain activation and improving muscle activation up to the 10 postoperative week. And third phase, focusing more and more on the rapid activation from week 10 to week 22 or other, if we decide to have another criteria for return to play. And now I suggest that we go into each of these steps with the idea to provide you what's the best evidence we have to do that. So normalizing sensory feedback. Remember, there is a disorganized sensory response coming from the receptors. We need to renormalize that. It's a difficult task, but I think you have to rely on biofeedback-based training. It should be at home and in the lab. If it is in the lab, there are tools today. This is a portable EMG device, $100. This is a portable accelerometer. Today we can do wonderful things with low-cost solutions, but you can do also that at home. Mirrors, whatever you want, altering the posture, and playing on the 3 main senses. We often forget that the main senses for proprioception are 3. The sense of position, the sense of movement, the sense of force, and a combination of the 3 will be the best. And altering continuously the condition, surprising your body, will be the key factor. And the variation, starting very easy and rendering it more and more difficult for your patients. Eventually, with such a solution, it's called the somatosensory electrical stim. It's very close to TENS, but it doesn't have the same effects. If you are interested, this is a nice review we published this year, where the idea is by applying this very light stimulation, it's almost sensory, so you feel it, but there is no contraction due to that, to peripheral nerve, you can maximize the sensorial feedback. And it seems very effective, especially in neurological patients. We don't know a lot about orthopedics. And then as a second approach, but less important, learning or education for the subsequent phases about what to do and why. And training uninvolved muscles. So yesterday we spoke about the importance of the hip. We spoke about the importance of core even for patients with a knee problem. I mean, that's the phase where you can maximize that, also in an attempt to maximize this sensory feedback. Maintaining brain activation, so basically focusing just on what happens here when I do this movement, okay? And here you have 2 basic solutions, which are very simple. They come also a little bit from neurological rehab, but now we have evidence from orthopedics, for example, in these studies here. Solution number 1, mental practice with all the associated options. That could be number 1, motor imagery. It's not imagining functional contractions or functional activities. It's doing imagined strength training. So you need to do 6 sets, 6 repetitions with 80% of the load. You imagine doing the contraction. You don't do the contraction. We know very well it works, just because the neural substrates or the neural cells, especially in the brain, which are activated by imagined contraction, are exactly the same as those neurons that fire when you do a movement. Oof. Action observation. Action observation is another good approach. So you observe somebody doing a functional movement, mirror, neuron therapy, very effective. Contralateral training, so basically you train the non-operated side. We know very well the mechanism, and we often refer to interhemispheric excitability. We are able, if I have this arm immobilized and I train this arm, I will maintain the activity in the contralateral cortex with good results on a long term. Improving muscle activation, so basically in an attempt to activate those fibers. You have two solutions. Number one, electrical steam, in particular this modality that for the last 5 years we have spent our time to validating this modality compared to the previous peripheral approaches. It's called multipath distributed. It's very effective to maintain it. The interest here is that we can have easy access to the some of the fast fibers just because they are superficial. And when we stimulate a muscle, we have access to these fibers. But we can preserve their function, together with a bunch of approaches that we can develop afterward, if you want, that I call neurocognitive, and that's here the link where the psychological factors become stronger. So contralateral steam, if I do an exercise on one side, for example, on the right side, and I do stimulation on the left side, I will maximize the activation on the right side. We know that very well. That's the same for eccentric contraction. If you do that exercise and you do eccentric on the contralateral side, you will maximize the activation here. This is a transcranial direct steam. We have evidence to say that we can increase for 30 minutes the number of motor units we can activate in a subsequent session, and that's absolutely pain-free. Psych-up, shouting, swearing, and producing very loud sound. So the famous startle response is very effective to maximize the activation and to minimize the pain. And there is plenty of evidence for that. Altering the emotions, priming, so motivating your subjects to do better and better, and rewarding, not only paying, but saying you did a wonderful contraction, that's the best you did. Drop jump 1 centimeter, tomorrow 2 centimeter, that's the best you did. That's priming, that's rewarding, sorry. Rapid activation, that's the key of my talk, and that's the problem now. So we're not interested in as probably discussed just before about strength, okay? That's a normal contraction. That's a 3-4 second contraction. We are not interested in that because if we go back to sport, we will have to produce force in between 100, 100 and 200 milliseconds. This is the most important phases in track and field. We didn't speak a lot about track and field, but I can do plenty of example in team sports. The important phase is less than 200 milliseconds. We need to be very good in that part. So we don't care about what happens here in reality. And that's probably why maximal strength is not that important. We care about what happens at the beginning. And now we have tools to measure that, rate of force development, and we have tools to train that. And to train that, it's simply what I call, to differentiate that from explosive training, it's ballistic. Ballistic is as short as possible. The contraction is less than 1 second. The important phase is 200 milliseconds. And that's very economic for the muscle, because there are no long contraction, no long fatigue, and it's quite effective, with a progression from isometric to concentric and eccentric as well. And then a second approach, if you want to maximize this quick activation, you induce ecological fatigue. So you take a soccer player after the first game he plays or he simulates, and then you train these fast contractions or the other techniques we have seen before to put them into the same ecological context. I will skip the evaluation phase, but that's basically attempting to tell you that quantifying maximal strength as a criteria for return to play is probably not complete information. Doing HOPE testing is probably not a complete information because one more time, the contraction lasts 1 second. The contact time during the HOPE test, we know we measure that. It's about 350 milliseconds and more if you have an impairment. That's not what we need. We need 100, 200 milliseconds. And we can do that in isometric or in dynamic condition by measuring the initial phase, the so-called rate of force development. There are posters here about that. There are plenty of studies going out. We are doing a review on that. Take-home messages, and I apologize if I am late. Neural impairment induced by injury and or surgery, serious physical and, in turn, psychological function. They represent serious risk factor for unsuccessful return to play. They should be avoided and treated as soon as possible. I showed you the 4 steps and the 3 keywords, and I really recommend you to focus on this aspect. Thank you very much.